watch this evolve.
Yeah, yep. But we have a long way to go.
Oh my God. But also, what medical knowledge doubles according to Google every 72 days. Somebody may be up on this stuff that we don't even know about.
Crazy.
I thought we'd give people another minute or two.
All right.
I know a while ago they were talking about 5 or 6 years ago, maybe exosomes and asthma. Have you any opinion about that?
Yeah, I mean, right now it hasn't really panned out as much as they initially thought, but you know, the big thing is there's a lot of activity going now that we learn more about the immunopathogenic mechanisms. But as I'll talk about, the issue is we have all these new biologics and everything, but nobody's been cured.
Right.
So, yeah, you know, we haven't been able to reverse the pathogenic changes or induce true immunomodulation.
I know it's much like so much of internal medicine is we stabilize patients, we don't cure them.
That's right. Yeah. And we really have to work more towards cure and, of course, prevention.
We have good attendance now, Dr. Sennett.
Great. Okay. Are you ready to be introduced, Tom?
I am, whenever.
This is John Sennett. It's my honor to introduce Dr. Casale. Dr. Casale is a globally recognized expert in asthma and atopic disease. He's going to go over newer approaches to asthma that would include biologic treatments for both asthma and other allergic diseases. And he's going to tell us how to use the biologics. I think this is critical because right now they're very expensive, hard to get, blah, blah, blah. But in a year, they're going to be the standard of care, I believe. Dr. Casale has more publications than anyone in the College of Medicine, which gets everyone happy, and is noted as a great thinker. Dr. Casale, teach us. Have a good day.
All right, thank you, John. My pleasure to be here today and talk about something that I'm very passionate about, and that is the use of biologics for the treatment of asthma and atopic diseases. So before I start, I'll just go through some of my disclosures. And they're listed here. So I do serve as a consultant for many of the companies that make a number of the drugs that we'll be talking about. So I have 3 objectives for today's talk. The first one is to describe T2 inflammation. The importance of that is the pathway that is the target for most of the biologics that are currently developed for the treatment of asthma and allergic diseases. And I'll review where we are today with these treatments for asthma and allergic diseases and discuss what's needed to better use these in caring for our patients. Let's see. Okay, so I wanted to show this slide. It's an older slide that I put together for a talk at a meeting in 2010. And what you could see is pathways with a number of different drugs that were under development for the treatment of asthma. And it was thought that now that we knew some of these important pathways, all we have to do is take out one of the mediators and we would make a big difference for the treatment of asthma. Well, a couple of years later, I updated the slide and took out the ones that didn't work. And that was most of them. And then if you look at today, there's only a few categories of the existing molecules that we were looking at just a dozen years ago that are approved for asthma. There's a number of reasons behind this. First off, it's important to remember that once a drug gets into clinical development, only about 1 in 8 actually make it to the approval process. A lot of them fail. And the other thing is that the immune system has a lot of redundancy. So if you take out one molecule, there might be another molecule that can fill in that function so you don't affect the pathogenesis of the disease to lead to better therapeutic outcomes. So this is very apropos. Your asthma stayed the same, but the research findings have changed. And we see this all the time with not only asthma, but a number of other diseases. We're continually learning more about the pathogenesis, and as a result, trying to develop new therapies. So mechanisms to help guide therapy. This was a review paper published just last year. A few things I want to point out. The airway epithelium initially was thought to be a very passive barrier, but in fact it isn't. It's a very active player in the pathogenesis of asthma. When you stimulate the airway epithelium, and that could be done through a number of different mechanisms, through viruses, bacteria, allergens themselves, because they have proteases that could actually disrupt the airway epithelium, you generate alarmins. And alarmins are molecules that are very important in influencing the immune response. The three that are probably most important are IL-33, IL-25, and TSLP. These ultimately convert innate lymphoid cells that are undifferentiated into ILC2 cells, and these are important because they produce cytokines that convert uncommitted T helper cells to Th2 cells. And both the ILC2s and the Th2s produce cytokines like IL-4, 5, 13, 9, etc. that are important for eosinophils to get into the airways and cause inflammation, and also to cause B cells to switch from making IgM to IgE, which is important in arming mast cells, so that when you inhale an allergen and you cross-link those IgE receptors, you release mast cell granules that can cause bronchoconstriction and inflammation. But the other part of this paradigm is what we call T2 low asthma. And in this particular scenario, you now have a disease that is manifested primarily by neutrophils. And the neutrophils are driven into the airways by a number of cytokines, one of which that we think is very important is IL-8. But also important to this is Th17 cells, which produce IL-17. And I'll go through these in a little bit more detail and specifically explain why some of the drugs that we're now using are being used and why we're trying to develop drugs that in particular block this T2 low pathway, because these are the patients that do not respond to corticosteroids. What's missing from this, even though this paper is only less than a year old, are T helper follicular cells, which have been shown to be very important in food allergy and now gaining prominence in other atopic diseases like asthma. So this whole concept of treating what we call T2 high asthma has been very important. And one of the things that you should do as a clinician when you see a patient with asthma is try and determine whether or not that patient does in fact have T2 high asthma. We have three basic biomarkers that we could use, none of which are really perfect, but they're the best that we have. So you could measure total IgE, and if a patient has an IgE between 30 and 1300, you're generally considered that they're probably allergic. Eosinophilic, which is manifested by either elevated blood or sputum eosinophils, or type 2, which is a combination of these two with elevated blood eosinophils and or exhaled nitric oxide. So as a clinician, when you see a patient with asthma, you could measure blood eosinophils. And the reason I say to do that is not only because this is an important biomarker to determine whether someone's going to respond to biologics, but in fact, this is some old data from quite a few years ago where they looked at patients and put them on inhaled corticosteroids. This is our single best therapy for the treatment of asthma. And I want you to notice that about 50% of patients, whether they're adults or children, either got worse or stayed the same with inhaled corticosteroids. 50%. And these are the people that primarily have T2 low asthma or asthma without a predominant neutrophilic or eosinophilic phenotype. The patients that you want to treat with corticosteroids and that will respond are those that have elevated blood eosinophils or sputum eosinophils. So if you characterize these patients, and in fact they do have T2 high asthma, we now have 6 different biologics approved for asthma that work. One that was just recently approved is called tezepelumab, and it blocks TSLP, thymic stromic lymphopoietin, which is one of the alarmins released from the airway epithelial cells. In addition, because we know that with asthma, whether it's allergic or non-allergic, a lot of people have high eosinophils in the airways, which are very important in inducing some of the pathogenic mechanisms critical to this disease. You can block that with one of 3 biologics. 2 are IL-5 blockers and 1 blocks the receptor for IL-5. Besides IL-5 and alarmins, IL-4 and IL-13 are very important. IL-4, as I said, is important because it causes B cells to switch into making IgE, which is critical to arm mast cells. And IL-13 can directly induce airway smooth muscle hyperresponsiveness, mucus production, and promote inflammation. And it's for that reason a drug like dupilumab, which blocks the IL-4 alpha receptor, the common receptor for both IL-4 and IL-13, has proven to be very effective. And then finally, omalizumab, which has been around the longest since 2003, blocks IgE directly. So this knowledge of T2 high inflammation has led to what I call the monoclonal expansion wars. And again, omalizumab was approved anti-IgE in 2003, but over the last 5 to 7 years, there's been an explosion of the approval of a number of other biologics, not only for asthma, but for comorbid diseases that often track with asthma. Dupilumab, for example, now has 6 different indications, the most recent being prurigo nodularis in adults. Well, why would it be approved for that? Well, because what's one of the major problems you have with this disorder? It's itch. And blocking IL-4 and IL-13 have been shown to be important in relieving the development of itch. So if you do these T2 elevations and you say, hey, you have high eosinophils, now I have 6 different biologics. Which one do I use? I'm confused. Well, if you look at some of the data for eosinophilic asthma, all these biologics were approved based on their ability to inhibit asthma exacerbations. And all of them have about a 50% reduction in asthma exacerbations. There are some subtle differences. So if you want to decrease oral corticosteroids, you would probably pick a drug like dupilumab, which is the only one it's approved for. If you want to improve FEV1, you're going to pick something like dupilumab or one of the IL-5 blockers, but probably not omalizumab because it has a very modest effect. So knowing the particular things that you want to do with a patient can help you decide. But these biologic require better knowledge of the biomarkers because, number one, we lack biomarkers for T2 low disease, and I'll go through this in a minute. And number two is that if you take people with the same biomarkers and put them on one versus another of these biologics, basically the response rates are pretty similar. And many of the responses are largely driven by the placebo. So what do I mean by that? This is an example of a study published in Lancet using an IL-5 blocker, mepolizumab. And you could see here the baseline eosinophil counts. When a patient is on placebo, the number of asthma exacerbations goes up as the blood eosinophil count goes up. So eosinophils are a good predictor of asthma exacerbations. The drug effect is pretty flat, but it looks like you actually get a bigger effect on inhibiting exacerbations, not because of the drug effect, but because the placebo patients are actually driving the number of exacerbations, so it looks like you're doing better. And this is an important point because in real life, you don't have a placebo. You're just picking a drug, so that sometimes you get results that don't mimic these phase 3 pivotal studies at all. There is another biomarker that we use for treating for trying to make diagnostic and therapeutic decisions for asthma, and that's exhaled nitric oxide. And what's been shown is that this is an important biomarker for drugs that affect IL-13. Why is that? Because the airway epithelium, when it's stimulated with IL-13, causes the production of inducible nitric oxide, so you generate more nitric oxide as a marker of airway inflammation. And this is a study that is in press that I'm an author on, where you could see that they're looking at different levels of exhaled nitric oxide and blood eosinophils. So if the blood eosinophils is low, less than 150, and the exhaled nitric oxide is low, you really have no drug effect at all. In fact, these patients did a little bit worse. But if you have an elevated exhaled nitric oxide, even in the absence of elevated blood eosinophils, a drug that blocks IL-4 and IL-13, you get about a 45% reduction in exacerbations. But here, when you have elevated eosinophils and elevated exhaled nitric oxide, you get almost an 80% reduction. So this is an example of what we would term precision medicine, if you would, where using biomarkers, elevated blood eosinophil, elevated exhaled nitric oxide, and this is something we do in allergy clinic, you could see that you have the sweet spot for this particular drug with a marked reduction in asthma exacerbations. And the data with FEV1 is also extremely good. So 3 biomarkers, they're not always helpful. And what do you do when they're not? Well, first off, we think about what is the patient really looking for, and how easy is it to deliver that? So these biologics that I talked about, the 6 of them, one is an IV preparation, one is an every 2-week preparation, and the rest are every 4 weeks. So the patient may have a preference as to which delivery system might be more important for them, and also what might be the potential side effects. The other thing is, what's the end game for the patient? And the importance of this is, what are you trying to achieve? If it's reduction in asthma exacerbations, across the board, I showed you that the data suggests that about 50% of patients, or 50% of exacerbations, are decreased with these biologics. But if you want to improve FEV1, you might pick a drug that affects IL-13. Comorbidities, very important, because we know that asthma tracks with a number of diseases. If you could get a 2-for-1, then that's great, and I'll show you some examples. And exacerbation triggers. If you're trying to prevent asthma exacerbations, if you know what the particular trigger is, that might influence your decision on which of these to pick. And of course, probably the most important will be insurance coverage. But let me go through these in a little bit more detail. So this is a paper we published a couple of months ago looking at biologics approved for asthma and the effects on various comorbidities. So this so-called atopic march starts with atopic dermatitis in very young children, progresses typically to food allergy, and then allergic rhinitis and asthma. These diseases tend to track together. If you have a child or adult with atopic dermatitis and severe asthma, you really have only one choice, and that is to use dupilumab, because it would treat both diseases effectively. We know that patients with severe asthma are much more likely to have chronic rhinosinusitis with nasal polyps, and that disease is harder to treat, makes the asthma worse. Now, omalizumab, mepolizumab, an IL-5 blocker, and dupilumab are all indicated for nasal polyps as well as asthma. And there's reasonably good data with benralizumab. Food allergy, more common in patients with asthma, good data with omalizumab, and they are in phase 3 trials looking to get an approval for food allergies. So if you have both disorders, you're more likely to pick omalizumab. And allergic rhinitis, omalizumab has the best data. Dupilumab has some good data as well. But there are no biologics approved for this, probably not because they don't work, it's just that it's hard to justify using such an expensive therapy for allergic rhinitis. So atopic dermatitis, a disease that tracks with asthma. The newest things that are out there that are now approved for atopic dermatitis and will likely make asthma better include JAK inhibitors. So when you have a cytokine and it binds to its receptor, JAK is phosphorylated and activates STAT. And as a result, the phosphorylated and activated STAT cause the transcription of various cytokines. And that's true for all the critical cytokines that are important in asthma. Now, when we look at atopic dermatitis, we can block IL-4 and IL-13, important for atopic dermatitis, with dupilumab. There are also 2 drugs that just block IL-13, had a marginally good effect in asthma, but are approved, at least tralokinumab, for the treatment of atopic dermatitis. Nemolizumab is an interesting drug that blocks itch. And of course, atopic dermatitis, itch is extremely important. And then the new kids on the block, and that is drugs that specifically block JAK. And they block different types of JAK. So right now there are 2 oral and 1 topical therapy for atopic dermatitis that are JAK inhibitors. The problem I see with JAK inhibitors are twofold. Number one, the adverse event profile tends to be higher than these monoclonal antibodies because JAK is present in a number of cells, different types of cells, important in general immunity. So you have to be careful that they might not develop a serious consequence of blocking that part of the immune system. And some of them have been associated with cardiovascular adverse effects as well. And the other thing is that even though these drugs are oral, small pills you take daily, you would think that they would be a lot cheaper than these big monoclonal antibodies, but in fact, they're not. So to treat atopic dermatitis with these approved oral JAK inhibitors cost approximately $60,000 a year. As I mentioned, food allergy often tracks with asthma. And again, looking at the same players, these alarmins, IL-4, IL-13, IgE, and IL-5, there are attempts now to use all of these in the treatment of food allergy, which we really have no good treatments for. So there's an ongoing trial with TSLP going to happen here in combination with immunotherapy. Preliminary study with IL-33 was promising, so blocking alarmins. Dupilumab has been trialed with marginal results. Omalizumab phase 3, second generation anti-IgE in phase 3, and the IL-5 blockers, not much in the way of data, but some promising results. Chronic rhinosinusitis with nasal polyps, again, tends to occur with asthma, make asthma worse, and now you could see the same players, and that's why some of these same drugs like dupilumab, omalizumab, and IL-5 blockers are approved. So if you have a patient with both disorders, you might treat them with one of the 3 drugs that are approved for both of them, because you could potentially relieve both upper and lower airway symptoms. Now, as I mentioned, the big thing about asthma is that people can have a relatively good quality of life, but then have severe exacerbations. And in this study that was published about a dozen years ago, the investigators looked at the effects of anti-IgE omalizumab in adolescents and young children in the inner city. And what they found is that in the placebo group, they had 2 big peaks in asthma exacerbations. The thought was that these were due to allergies, because here you have springtime allergies, here you have fall allergies. And that was completely blunted with omalizumab. But when the investigators looked further, what they found is that these exacerbations are primarily mediated not by allergies, but by viral infections, also peak during these times. So when the kids go back to school, big increase in rhinovirus infections, for example, and then after the holidays, there tends to be another one. So the question is, if you have patients that have exacerbations primarily due to viral infections, would one of these biologics be better than the other? And the answer is probably yes. So this is a paper we published a couple of years ago, Juan Carlos Cardet and myself, and it's based on some data that shows that if you have allergies, your dendritic cells have high affinity IgE receptors with IgE that captures allergen. When that happens, that dendritic cell has inhibitory pathways so that it produces less interferons, and as a result, not as protective against viral infections. When you treat someone with anti-IgE, and in particular omalizumab, you knock out the IgE, and as a result, you also knock out the expression of high-affinity IgE receptors. When that happens, the dendritic cell now is capable of restoring its ability to produce interferons, and that's been shown to result in fewer viral infections, fewer viral asthma exacerbations with decreased duration of infections as well. So if you have a patient with a large number of exacerbations that you think are due to viral infections, and they have allergies, you might pick omalizumab as your drug of choice. So the initial evaluation for a patient, what types of things do we look at? We look at BMI because we know obese patients with asthma may not in fact be T2 high. Often they might be T2 low. Exacerbation history, comorbidities, lung function, and then do their biomarkers. So again, we measure FeNO in our clinics, but in primary care, you could certainly measure blood eosinophils, and then think about what the goals of therapy are. You're trying to reduce exacerbations, improve symptoms, quality of life, reduce corticosteroids, and pick the biologic based on that, and then reassess at 4 to 6 months. So why do you have to wait so long? Well, if you're really looking at whether or not a patient achieves a reduction in exacerbations, you need at least that long. A lot of patients only have maybe 1 to 3 exacerbations a year. And if these biologics reduce the incidence of exacerbations by 50%, you would never know that if you only followed them for a couple of months. Lung function improvement, on the other hand, with certain of these biologics, happens quickly. So here is an example of improvement in FEV1 with 3 different biologics. The newest one approved, tezepelumab, you could see within 2 to 4 weeks, a nice improvement in FEV1 versus placebo. You could see that with an IL-5 blocker, reslizumab, and a little bit more modest, but still within 4 weeks, improvement in FEV1 with mepolizumab. So this might give you a hint as to whether your biologic is working if the patient has a low FEV1 and you follow them over a month or 2. If the goal is to reduce oral corticosteroids, then dupilumab is the only one that's indicated, but there is good evidence for 2 of the 3 approved IL-5 blockers, benralizumab and mepolizumab. You reassess the patient at the end of that 4 to 6 months, and then you think about certain things if they do not respond. First would be inadequate dosing, in which case you might consider switching to a biologic with different dosing. So reslizumab and omalizumab are the 2 that are dosed based in part by body weight, and that may help. This is a study looking at individuals that are corticosteroid dependent. They were placed on mepolizumab, an IL-5 blocker, and they didn't do very well. So they had a 12-month washout, and then they switched them to reslizumab. And the reason they switched them to reslizumab is because it was weight-based dosing, and these patients tended to be overweight. And what they found is that if you look before and after reslizumab, sputum eosinophils, a good marker of airway inflammation, only with reslizumab did that really go down. And that was associated with improvement in ACQ-5, which is an asthma measure for symptoms, much better than just mepolizumab. as well as FEV1% predicted, improved with reslizumab. The other things that we consider, some of these are associated with anti-drug antibodies. This is reported, especially, for example, with benralizumab, although it's not clear that they really make a big difference. They could have persistent T2 high inflammation, in which case, even though you gave them a blocker that should affect T2 pathways, in some patients, a particular pathway might be more important. So IL-4 and IL-13 in one patient, IgE in another, and perhaps IL-5 in another. So if you have someone on an IL-5 blocker and they don't do well, maybe you want to switch them to one of the other categories of drugs. There are no publications on switching a biologic to omalizumab, but switching from omalizumab, there's many publications that show that in certain individuals, they may get better. Tezepelumab just approved, so we don't know. And there are multiple publications on switching to and from reslizumab, mepolizumab, benralizumab, the three I5 blockers, to dupilumab. Here's an example. Here's a smaller study where there are patients that are treated with mepolizumab, benralizumab, reslizumab, or omalizumab, and they didn't do very well. They switched them to dupilumab, and 29 of 38 responded. ACT, asthma control test, not a college entry exam, went up, and it went up in a clinically meaningful way. Asthma exacerbations markedly decreased. The dose of prednisolone decreased, and all these in the 29 patients that responded were pretty dramatic. But what was interesting is not everyone responded, but in the responders, like we indicated before, looking at a certain biomarker, in this case, XL nitric oxide, you could see that 23 of the 26 responders had an elevated XL nitric oxide, and we said that that's a good marker for potential responsiveness to dupilumab. However, I have to say that switchers are not always good. So in this case, a patient was switched to dupilumab, and they developed eosinophilic pneumonia. And the question is, well, why did they develop eosinophilic pneumonia? When you block IL-4 and IL-13, you're essentially decreasing the ability of IL-4 and IL-13 to induce the expression of adhesion molecules called VCAM on endothelial cells, which is critical for eosinophils to bind to the endothelium and then migrate out into the site of inflammation. So when you treat somebody with dupilumab, by blocking that ability to express these adhesion molecules, the eosinophils stay in the circulation and increase initially. And in some cases, that could lead to a pathogenic effect. In this case, you could see a patient with hypereosinophilia that wound up with a deterioration of asthma and developed a serious complication of eosinophilic pneumonia. So it is something to keep in mind that switches
on the web for dose complication of
not always good. Now, the biggest problem we have with treating asthma, as I indicated, about half of the patients with severe asthma have either non-eosinophilic airway inflammation, that is neutrophilic inflammation, or they have what we call a lack of obvious inflammation. So they may have more problems with airway smooth muscle or other mechanisms that contribute to their disease. It's a review paper we published last year looking at non-T2 neutrophilic-driven inflammation. These patients are corticosteroid insensitive, so it doesn't matter how much corticosteroids you throw at them, they may not have a good response at all. And now we see that one of the critical things that happens is that you have certain cytokines like IL-6 and IL-23 that cause the differentiation of Th17 cells, which produce IL-17, feedback on the airway epithelium with the release of IL-8, and this is a neutrophil chemoattractant. So because we think that these might be important cytokines in inducing neutrophilic inflammation, there are a couple of trials ongoing now to look at their effects. And here's some data on plasma IL-6 levels. You can see in patients in this cohort from NIH, the SARP cohort, severe asthma, that the levels of IL-6 are quite a bit higher than healthy individuals. And the level of IL-6 was fairly well correlated with the degree of the number of asthma exacerbations. Because of that, Juan Carlos Cadet in our division is involved in a study testing an anti-IL-6 blocker, clazakizumab, in an NHLBI-sponsored PRECISE study on severe asthma. So we'll have to wait to see if that IL-6 is a reliable biomarker for predicting responses and whether, in fact, anti-IL-6 is a good treatment option. We mentioned that IL-23 is also important, and in this study published a couple of years ago in New England Journal, they looked at the effect of a monoclonal antibody against IL-23, and they found that there was, in fact, a decrease in transcriptional gene signatures of Th17 and Th1 cells, but they had no effect on asthma. In fact, they had a worsening effect. So here we're looking at time to first asthma worsening. It was about half the time in the patients treated with the IL-23 blocker versus placebo. So in this case here, the biologics can be useful because sometimes we make a hypothesis that blocking this should really work and treat a particular phenotype or endotype of the disease. And you could see in this case, that's not the case. Some of the other things that we're looking at, again, IL-6 blockers, IL-17 blockers, and I'm working with some collaborators at Creighton University looking at some small molecules that inhibit the transcription factors critical for the development of Th17 cells, which ultimately produce IL-17 and drive neutrophils into the airways. So what about targeting IL-17? We found that IL-17 levels are elevated in bronchial tissues, in PBMCs and serum and asthma, and associated with increased airway hyperresponsiveness and asthma severity. And the IL-17F levels are also increased in asthma and correlated with airway neutrophils and more severe disease. But there have been two clinical trials of humanized anti-IL-17 monoclonal antibodies, one of which is approved for a different indication, and they both failed. And then there was a trial of brodalumab, monoclonal antibody that binds to IL-17RA, and it too failed. So the question is whether or not IL-17, blocking IL-17 is a reasonable strategy. We don't know. We don't know because there's a lack of good biomarkers. So when the IL-5 blockers were first being developed, and there were several studies published in New England Journal, Lancet, that showed that they decreased blood eosinophils by 95 to 98%, but they had no clinical effect. when the investigators finally figured out if you enrolled patients with elevated eosinophils, then you had a clinical effect. Those drugs were ultimately studied in the right population and approved. With T2 low asthma, since we don't have any good biomarkers, we might be doomed for failure if we don't get the right patients. We do know that things like allergen immunotherapy are not appropriate. And the other thing that we're concerned about is, what are we trying to do with this? We're trying to prevent neutrophilic inflammation. Well, that could be a downside as well, because we know that certain of these biologics, when they really inhibit neutrophil function, then you're predisposed towards adverse consequences like infections, or in some cases, even malignancies. The T2 high biologics that we currently have, there's some minimal data out there that suggest in a subset of patients, they might get a little bit better, but in general, they don't work well. And the only thing that recently might work would be to consider alarmin blockers, because they're higher up in the immune system. If you look at the three alarmins, what's been shown is that, blocking IL-33 has been looked at, blocking IL-25 has been looked at, neither of which have been extremely successful. And I'll show you an example of that. And then, of course, blocking TSLP, which has been successful. Study published in JACI, and this is looking at a drug that blocks the receptor for IL-33. They used 3 different doses versus placebo. All comers, about a 35% reduction in exacerbations, but it had a similar effect in patients that had low blood eosinophils, and in the high dose, about a 50% reduction. So there is some hope that blocking IL-33 or its receptor might prove to be effective for T2 low asthma. But this study was then published in New England Journal, and they actually looked at an IL-33 blocker itself with and without dupilumab. And really, it was a negative study. So the effect of this drug was very marginal. It was certainly no better than dupilumab. And interestingly, the combination of the two, which you would think would be much better, did not prove to be any better at all. So a confusing result, nonetheless, did not indicate a potential promising role for this drug in the treatment of severe asthma with T2 low asthma. Tezepelumab was just approved late last year for the treatment of asthma, and unlike the other biologics that I mentioned, is the only one that's approved for severe asthma, regardless of whether they have a T2 high phenotype or not. But if you look at the data, patients clearly do better with higher eosinophils. Here is a reduction in asthma exacerbations, much higher if their eosinophil levels are higher. And you could see the same trend, much better reduction in exacerbations if their exhaled nitric oxide is higher. So, big questions for this 50% of patients with asthma. Are we doomed to failure without point-of-care biomarkers that allow for patient enrichment for clinical trials? Perhaps yes, and that's a real issue. And it's important to recognize, I keep talking about eosinophilic and neutrophilic, but these things are not they're not pure, and they're dynamic. So you could be someone that has high eosinophils, a mixed eosinophilic, neutrophilic picture, and it's important that nothing in these types of phenotypes are absolutely pure or stagnant. And then again, what are the consequences of inhibiting neutrophils in the lung? So in summary, biologic therapies have been helpful in defining the pathogenesis. So if we take out a particular molecule and it doesn't make a difference, then we know that that molecule may not be as important as we thought. They do provide some better therapeutic options. They decrease symptoms, they improve quality of life, they improve the course of the disease, but none of them have been shown to reverse the pathogenic and physiologic changes and induce true immunomodulation. By that, I mean, none of them have been shown where you could treat someone for a finite period of time, and that period of time could be 5 years or longer, and stop it and have a remission of disease. Fortunately, the ones we have had pretty good side effect profile. They're marginally cost effective, especially if you have a patient that has a lot of exacerbations, because they all cost 25 to 50,000 a year. And again, none of them induce immunomodulation. And what we really want to do is to prevent disease. So there's an ongoing study now looking at whether 2 years of the anti-IgE monoclonal antibody in children 2 to 3 years of age will prevent asthma. And very interestingly, looking for that holy grail, there was a study just published, and that is looking at dupilumab, whether or not it's able to attenuate the atopic march, that march from atopic dermatitis to food allergy to allergic rhinitis to asthma. And what they found is that overall, once these patients with atopic dermatitis that were pooled in this study were placed on dupilumab, they had about a 37% reduction in comorbid atopic disorders. So providing some hope that maybe we can prevent some of these diseases. So in summary, biologics for asthma and allergic diseases are here to stay, but we still haven't mastered the best criteria to select patients for a specific therapy. It's likely that increased knowledge of the immunology of the disorders we treat will lead to more therapeutic options. Disease prevention is possible, and if you're going to try and prevent disease, the study that I showed you with omalizumab makes the most sense. Starting patients when they're very young, and even 2 to 3 years of age might be too old because they already will have atopic dermatitis. So there's a lot of questions, but I still think there's a lot of hope, and we've made significant progress over the last 10 years. And ultimately, what you want to do is to find something that works as good or better than steroids, but costs much more if you're a pharma company. We can't support all these biologics, and we have to have a better way to pick the right patient and the right drug. So thank you very much, and I'd be happy to answer any questions.
That was fantastic. I know there are questions. Go ahead and start asking.
This is Dennis Ledford. I thank you, Tom, and I think we're privileged to have someone who has such a knowledge of the literature and is contributing to the research, and every now and then actually sees a patient. It's amazing. I think as an internist too, we need to keep in mind that only 25% of people use inhaled corticosteroids as they're asked to. Most people with asthma like to vary their medication. It's the first thing we always have to think about, I believe, before we start worrying about biologics is, are they using their medications and do they really have asthma? So I think it's very important for us as we see patients in clinic that we go over that, because inhalers are intuitively very difficult to use. And again, Dr. Cardet just recently published in an underserved community how variable dosing inhaled steroids actually improves outcomes. So there may be some strategies before the monoclonals. But Tom, would you comment just briefly about the possibility of intermittent therapy from your perspective? You showed that very nice, elegant study looking at spring and fall exacerbations. So maybe one strategy with biologics because of their expense would be to use them intermittently, kind of anticipate when the bad time of the year is, start the biologic, and then when you get through that, quit it. Do you see that as being a possibility? Thank you.
Yeah, thank you, Dennis. I absolutely do. And I tried to pitch this to Genentech maybe 12, 15 years ago and have been harping on them to no avail. But I do think that if we could identify exacerbating triggers as well as the most common time for those exacerbations, coming up with a strategy that would prevent those particular episodes without year-round therapy would be a more cost-effective way.
Dr. Liggett?
Let me get my mic undone. Yeah. So one thing that I was wondering about, because I'm actually struggling with this myself, is how it's a terrible question to have to ask because we really want to look at the science and the clinical component, but we have to face the fact that there's a lot of guardrails up against using some of these compounds from the insurance company. So have you seen any lightening or up of that, and what do you foresee as the future? Because those of us who are candidates are constantly having to sort of prove ourselves. It's a little demeaning.
Yeah, and I think that's a good point. And certainly for some of these drugs, like the IL-5 blockers, for example, you can't get one approved very easily unless you show them that you have elevated blood eosinophils. So in that case, you can reduce the dose of inhaled corticosteroids temporarily. I mean, there's certain tricks you could do to hopefully get their eosinophil levels up to a certain level that would guarantee approval. And of course, eosinophils vary by time of day. So again, knowing what time of day when endogenous corticosteroid levels are lowest, early morning might be another time to draw the blood eosinophils. So we try and do those types of tricks if we have to.
And do they still care if it was 3 years ago or 5 years ago or whatever?
They do, and oftentimes they would like to see that within the last year or 6 months. So that can be a problem. And one of the other things that we run into is like, well, you're using a biologic, and the idea is that you could prevent or decrease the use of inhaled and oral corticosteroids.
Right, exactly.
And if you're successful, then the insurance company comes back and says, well, you no longer need a biologic. You're not on your inhaled steroid. So It is a problem.
Okay, thanks.
Yep.
There are a couple questions in chat. Do you have access to them, Dr. Casale, or would you like me to read them?
If you don't mind, you could read them. That'd be great.
Sure. Dupilumab is approved for treatment of eczema in patients with eczema and psoriasis overlap. Is it true that dupilumab may exacerbate psoriasis?
So dupilumab is not approved for psoriasis. And I'm not aware of any particular data that shows that it can exacerbate psoriasis, although psoriasis tends to be more of a Th1 driven disease. And what's been shown is that if you block a Th2 pathway, you may actually increase the amount of Th1 inflammation. So from a theoretical standpoint, it is possible that you might have some issue with psoriasis, but I'm not aware of any particular data.
A second question, recent pilot paper in JACC about PCSK9 inhibitors for decreasing IL-6 to blunt inflammatory phase stage of COVID. Has anyone tried it for the asthma phenotypes who may benefit?
They have not, and I think that's a reasonable, as I said, I think some of these smaller molecules that might affect particular transcription factors important for the generation of neutrophilia would be important. what has been shown for COVID, and something that we briefly touched on, there was a recent study that indicated that maybe patients do better with COVID when they are on anti-IgE because of that restoration of their dendritic cells to produce interferons.
Dr. Liggett, did you have another question?
No, I just didn't take my hand down. Sorry.
That's okay. That's all from chat.
All right, well, thanks again for listening, and hopefully you could pick these biologics a little bit more rationally, because they're out there, they're very expensive, and we clearly have to be careful in who we treat.
What a wonderful presentation, Dr. Casale. Thank you very much.
Thank you, John. Okay,
Keep up the good
bye-bye.